Hi, welcome. We are going to get started now with Dr. Mona Sazgar. She is a neurologist at UCI Health talking about prenatal and postnatal care of women with epilepsy. Thank you for offering this today, Dr. Sazgar.
Thank you everyone for joining in. As you know, my passion is caring for women with epilepsy, and I'm an epileptologist at the UCI, and today's talk is about both prenatal and postnatal care of women with epilepsy. So I know that a whole lot of talks in the past has been about prenatal care, but what about after the baby is born? And we're going to cover both. I start with a case vignette. A true patient, SB, is a 28-year-old woman with a long-standing history of focal epilepsy. Her epilepsy was due to right frontal abnormal tissue called cortical dysplasia. She used to experience clusters of her seizures fluctuating with her hormones about 2 days prior to her menstrual bleed and throughout her menstrual period. As you are aware, this is called catamenial epilepsy, when the seizures fluctuate with the hormonal levels. Some of her seizures in the past progressed to generalized tonic-clonic activity, but luckily in the past 2 years, the patient was stable, seizure-free on oxcarbazepine, 900 milligram twice daily, and did not report any seizure recurrences. As soon as she started dating and her social circumstances changed, her neurologist put her on folic acid, 1 milligram daily. And then she got married last year and was taking a birth control pill, a combination of estrogen and progesterone. She comes to a neurologist's office and she informs her that her pregnancy test came back positive. She's shocked, obviously. She was not supposed to become pregnant on the birth control. And to make matters worse, she also started experiencing a couple of typical auras in the past 2 weeks. So she has a ton of questions regarding why did the contraceptive method failed, and about the reason for her seizure recurrence, now what's going to happen to my baby, and any future directions. That brings us to women with epilepsy who face a number of problems that are unique to their gender, and those special concerns start from the time of puberty, menses, birth control issues with conception, during pregnancy, childbirth, childcare, and even after menopause. There are specific issues for women with epilepsy that we need to address. And my talk today is about both prenatal and postnatal care. In the prenatal care, I will cover oral contraceptives and seizure medications. AEDDL stands for anti-epileptic drugs. What happens to seizures during pregnancy? Do they get better? Do they get worse? What is the natural course during pregnancy? The use of seizure medications during pregnancy, the benefits of folic acid supplementation, and then also I'll talk about breastfeeding and seizure medications. When I get to the postnatal care, I talk about adjustment of seizure medications postpartum. What are triggers of seizures in postpartum women with epilepsy? About maternal seizure management after the birth of the child, developing a safe parenting plan in women with epilepsy. And also we will touch upon contraception after giving birth and the postpartum depression in women with epilepsy. As we all are aware, epilepsy affects about 1% of population. Well, half of the population are women. So there are about 1.5 million women of childbearing age in the US who have epilepsy. Of these, about 24,000 give birth each year. The sad thing is that many healthcare providers are unaware of the specific issues about women, or they just are uncomfortable to address them, or they don't have enough knowledge about them. So it is absolutely important to initiate aggressive educational effort to make sure that both the providers and the people with epilepsy know about all of these issues. Let's start with contraceptive failure and seizure medications. Some of seizure medications can result in contraceptive failure, and we need to know which one of these, and if the patient is on those medications, contraception is not going to work, so they need a second barrier method in that case in order to prevent pregnancy. This is a chart that shows the medications and their interaction with the birth control pills. The top part, the red part, is the ones that definitely cause failure of the contraception. So if your patient is on, or if you are on birth control and simultaneously you're taking carbamazepine, clobazam, eslicarbazepine, oxcarbazepine, down the list on that red part, it means that there is a high risk for pregnancy because these medications can make the contraception less effective. The yellow part in the middle, that is the three medications, felbamate, prampanel, and topiramate, that if you take them at high doses, that can cause contraceptive failure. At a low dose, they may be safe with contraception. The green are the medications that if you take them along with the birth control, the pill does not fail. So they do not cause contraceptive failure. And those are like clonazepam, etosoximide, lamotrigine, pregabalin, down the list. All of these medications, they do not cause contraceptive failure. My next slide is going back to our patient. We know that her contraceptive failure was as a result of being on oxcarbazepine, which was one of the medications included in that red zone. It is a hepatic enzyme inducing medication, meaning that it makes the birth control less effective. So the neurologist should have recommended a second barrier method if they were really serious about contraception. And if they are using a birth control, an estrogen component, that has to be more than 50 microgram to be effective. But we all know that medications, that the birth control that has more than 50 microgram of estrogen can also increase the risk of blood clot and other issues in women. So we don't really want women to be on high dose of estrogen just for contraception. The other thing is Depo-Provera, which is injection of high dose progesterone, which can occur every 3 months. And Depo-Provera can be effective, an effective contraceptive method in women with epilepsy. But the progestin-only tablets, they are not recommended because these are if you want to use it for just seizure control, that's okay, but if it's for contraception, it's not going to work. The low dose pill, mini pills are not appropriate in this population. There are the method of choice is usually IUD, the intrauterine device. The copper IUD is the one that does not have levonorgestrel, does not have the progesterone release. And there are multiple in the market that have levonorgestrel, which is the basically progesterone. And those are Mirena, Liletta, Kylena, and Skyla. There are specific seizure medications that interact with oral. Actually, the interaction is the other way around. So if you are on a birth control, lamotrigine level will drop. Like if you become pregnant, it will drop by more than 50%. And that drop is usually due to estrogen rather than progesterone. Even women who are on hormonal replacement therapy, like postmenopausal, if they are on estrogen, the level of lamotrigine can drop. So they may have more seizures as a result of drop in the level of lamotrigine. So it is important also to know the other way interaction, that sometimes this, the birth control can affect the level of the seizure medication. Okay, Okay, so let's talk about epilepsy and pregnancy. What happens to seizures during pregnancy? We talked about each year, 24,000 women with epilepsy become pregnant in the United States. So when I usually consult patients regarding what happens to seizures during pregnancy, I quote what is on this slide. 20 to 35% of patients of women with epilepsy can have worsening of their seizures during pregnancy. About 55%, there is no change. If they had good control, they will have good control during the pregnancy. But about 10%, only about 10% can show improvement in their epilepsy. So there is always that proportion of patients, about 20 to 35%, that can experience more seizures or more severe seizures during pregnancy. Now, we talked about catamenial epilepsy. We talked about people who have hormonal epilepsy, meaning that their seizures fluctuate with their hormones throughout the month. The good news is that these people, when they become pregnant, actually their seizures can get better during pregnancy. So this is based on a study of Cagnetti and colleagues in neurology published in 2014. They followed 59 women with catamenial epilepsy and about 215 women with epilepsy that was non-catamenial, it was non-hormonal. And they found out that in the group with catamenial epilepsy, 79.7% remained seizure-free during pregnancy, as opposed to the other women who were only 22.3% remained seizure-free. So that's a huge number. About 80% of these women, actually their seizures got better during their pregnancy and they did not have a seizure recurrence. And then when they looked at seizure improvement, they found out that 50.8% in the catamenial group, as opposed to 8.4%, had reduction in their seizure frequency. So there is one bit of good news for catamenial pattern, and that is that catamenial pattern can be a predictor of better pregnancy outcome. Now, what are the causes of seizure recurrence when a woman with epilepsy becomes pregnant? Number one is discontinuing or lowering seizure medications. Like a lot of patients, when they are referred to me and they are pregnant, the reason that they start seizures is that they're so afraid of the seizure medication, they either discontinue it or they lower it, or maybe the neurologist doesn't have enough information and tell them to lower their seizure medications. And that is one of the, that's number one cause of seizure recurrence. Sleep deprivation, the anxiety and stress that comes with the pregnancy, the increased estrogen to progesterone ratio, especially in the first trimester of pregnancy, in the first 8 to 16 weeks. And then also the reduction in plasma concentration of seizure medication. You get bigger, you have more volume in your body. So the amount of seizure medication in your blood drops. There are certain medications that show even more drop in levels during pregnancy compared to other medications. Lamotrigine, oxcarbazepine, phenytoin, phenobarb, and levetiracetam. These are the medications that can drop more rapidly and more significantly. And that is why when somebody becomes pregnant and calls our office, the very first thing that automatically is done is that do a stat level of the seizure medication and then do it monthly so that we can adjust the seizure medication during pregnancy and avoid seizure recurrence. Our patient, remember, as we started experiencing some auras, it was because of reduction in the level of oxcarbazepine because of pregnancy. So the dose of the medication was adjusted several times during her pregnancy, and we were able to keep her seizure-free until like the pregnancy was over. Why are seizures bad in a person who becomes pregnant? Seizures by themselves can be predictive of poor outcome. And it's even irrespective of patient being on seizure medication or not being on seizure medication. Epileptic seizures during pregnancy can result in falls, can result in damage to the pregnancy, to the baby. Also, the more seizures during pregnancy, the more likely that the patient will end up having preterm delivery, low birth weight at the time that the fetus is born, the baby is born. Also, there is more risk of small for gestational age. And the more seizure the mom has during pregnancy, the lower the IQ in offspring. So there is a correlation with the number of seizures during pregnancy and the IQ of the baby. So that is absolutely important to prevent seizures during pregnancy. And obviously, stopping seizure medications is not an option for women with epilepsy who have active seizure disorder. What are the birth defects and what kind of birth defects can you see in general population, especially in patients with epilepsy? In up to 10% of pregnancies in women with epilepsy, the malformations, the trouble with the baby is the kind that can affect basically midline structures. So mid-face malformations, trouble with cleft lip, cleft palate, sometimes midline heart defect, some skeletal defects, spina bifida, and there is also risk of a language acquisition delay, so trouble with speech delay in the kids born to women with epilepsy. About 1.2 to 6.2% can have a developmental challenge and language acquisition delay. Now, in the general population, the actual risk of malformation in the babies is 2 to 3%. So pregnancy by itself is not always safe. 97% of pregnancies in normal people who do not have any disorder, who are healthy, 97% can give birth to normal kids, and about 2 to 3% can end up having some sort of major problems in their babies. So it's not just a matter of epilepsy, it could also happen in general population. Now, women with epilepsy who take seizure medications, that risk is about 4 to 6%. So it is higher than general population. There are certain medications such as valproic acid that the risk of spina bifida is higher with that. That's about 1 to 2%. And carbamazepine, the risk of spina bifida is about 0.5 to 1%. This is a very useful chart. It shows a lot of seizure medications. It's based on the North American anti-epileptic drug registry. So these are women with who were on these medications: gabapentin, zonisamide, oxcarbazepine, levetiracetam, lamotrigine, clonazepam, all the way to valproic acid. You see that this shows the risk. This part of the graph is the percentage of major congenital malformation. These are the control people. The pink is people who were on no seizure medications. The risk of congenital malformation in the babies was about 1.6%. And then if you look at this graph, you see that the highest risk was people who were taking valproic acid. 8.9% had major congenital malformation in the babies. Phenobarb is the next, that's about 5.9%. Topiramate is next, 4.4%. And then as you come to carbamazepine, phenytoin, and clonazepam, you see that the risk is lower and lower. Lamotrigine, the risk is 2.1%. Anything 2% and less is basically safer. So these are the safer medications during pregnancy. And from clonazepam up, you see that these are the ones that have much more risk than general population. So this is the North American Pregnancy Registry. There are multiple other pregnancy registries that they actually follow patients who are on seizure medications during pregnancy to see what are the risks to the babies. So there are certain medications that the risk is comparable to general population. And you see that on this graph. Just to reiterate, Valproic acid has the highest risk, 8.9%, phenobarbital 5.9%, carbamazepine 3%, phenytoin 2.8%, lamotrigine 2.1%, levetiracetam 2.0%. So these are, again, the lowest risks are down the list, and the highest risks are up the list. Let me talk about a couple of medications that have higher risk of cleft lip and cleft palate. Lamotrigine is one of them. There is a high prevalence, 8.9 per 1,000, of non-syndromic cleft palate and cleft lip. These are basically something that is treatable. People like plastic surgery can take care of that. In general population, the risk is about 0.5 to 2.6%, as opposed to 2.5 to 2.6 per 1,000, as opposed to 8.9 per 1,000 in patients who are taking lamotrigine. With topiramate, FDA have a warning sign regarding congenital malformation, because the risk of cleft lip and cleft palate with topiramate is 6 times more than general population. So what about risk of developmental delay, neurodevelopmental problems? There is a study by Mader and colleagues that they actually followed the infants that were born to moms who were on seizure medications during their pregnancy, and then they followed them at 3 years. They did a neuropsychological assessment. Then again, at 6 years, they did neuropsychological assessment to see what is the effect of that seizure medication on development of the child. And they found that from all the risk factors, the exposure to valproic acid in utero was predictor of reduced verbal IQ in the infant. The other risk factors were low maternal IQ. So if somebody has low IQ and they become pregnant, there is more risk that their kids will also have lower IQ. The other risk was the number of convulsive seizures during pregnancy. We talked about that. The more seizures during pregnancy, the lower the IQ in infant, and the risk is higher. And then also polytherapy. If you're on more than one seizure medication, the risk is higher for developmental delay in children. So with our patient, she was on oxcarbazepine, and the risk was comparable to general population. So at least she was safer during pregnancy on this medication. And the recommendation was, because it doesn't have an alarmingly high risk to her baby, she should continue on medication during pregnancy. We even adjusted the dose to higher during pregnancy, and she continued on folic acid. What about folic acid? Why is it important to take folic acid? This is an essential vitamin, basically, that during gestation. This folic acid is necessary for tissue growth in the fetus. So the recommendation of CDC is that to prevent neural tube defect, to prevent spina bifida, all the population, all women of childbearing age should take at least 0.4 milligram of folic acid daily. So this is general population. This is not like talking about only epilepsy patients. All of the studies were done in women in general. But we know that 50% of all pregnancies in the US are unplanned. So it is important that before you become pregnant, before you even, even if you don't have plans to become pregnant, if you are sexually active, to take folic acid. Because by the time people find out they're pregnant, it's too late to start taking folic acid. So basically, there was also a meta-analysis done by Dr. Wald and his colleagues. They looked at a lot of studies of folic acid, and they tried to find out what was the dose that people were taking during pregnancy and what was the outcome. And they found out that at 5 milligrams of folic acid daily, 85%, there was 85% protection from neural tube defect. However, there is a catch, and that is that the more is not the merrier. So if you take mega dose of certain vitamin, it doesn't necessarily mean that you're better off. There was a recent population-based study of more than 2,000 mother-child pairs in Spain that they actually found out that higher doses of folic acid, more than 1 milligram a day, was associated with increased risk of small for gestational age at birth. They even correlated the higher dose of folic acid with lower level of cognitive development in children 4 and 5 years of age who were born to mother who took folic acid at high dose. So take folic acid, but don't take too much of it, basically is the message here. Only consider higher dose for patients taking medications that can interfere with folic acid pathway, basically with the metabolism of folic acid. So if the patient is on valproic acid, if they're on carbamazepine, phenobarbital, phenytoin, and primidone, those are the medications that interact with folic acid. They interfere with the metabolism of folic acid. In those cases, it is warranted to use maybe a little higher dose of folic acid, but in other patients, we recommend no more than 1 milligram of folic acid during pregnancy. So the rest of the recommendation during pregnancy is to follow up with high-risk obstetrician, also follow up with your epileptologist regularly, do an ultrasound in the first trimester, and do a level 2 ultrasound around 16 to 20 weeks of gestation to look for detailed anatomy of the baby, make sure everything is okay and normal. And then there's also the AFP tests of serum, there's amniocentesis, depending on the age of the mother, they may choose to do that. And in combination, all of the above, you can detect 95% of the congenital malformation early enough so that the mom can make a decision regarding that pregnancy. Other recommendation is that when possible, hopefully before pregnancy happens, try to simplify seizure medications to only one, if possible at all. So if patient can remain seizure-free only on one AED, then and then try to use the lowest effective dose prior to pregnancy, so that that will guarantee better safety during pregnancy. And then the close monitoring and adjustment of seizure medication is recommended. So that is why we do monthly seizure medication levels during pregnancy to adjust the level to the pre-pregnancy levels. Breastfeeding. So the next step is talking about, okay, the baby is born and what are they gonna do regarding breastfeeding? There is no doubt that there are multiple benefits of breastfeeding. There's reduced infant mortality, there are fewer infectious disease, there is boosting of immune system in the infant, decreased risk of diabetes type 1, even the cognitive development of infants who are breastfed is better than infants who are not breastfed. So the general recommendation is that women should breastfeed their infants for at least 12 months of life, the first 12 months of life. Now, there was an important study in actually women with epilepsy who were taking seizure medications to compare the level of seizure medication in the blood of mom compared to the infant, and to see what is the exposure of infant if they breastfeed. So they had 351 women and 345 infants who were born to these women. And they were on they measured 7 different seizure medications that they were on. So these are carbamazepine, and then also the carbamazepine epoxide. That's another thing that they could they measured. Oxcarbazepine, levetiracetam, lamotrigine, topiramate, valproic acid, and zonisamide. So these patients, these women, were on all of these medications when they were breastfeeding. So, each one of them were on different medication. 64.3% of infants were breastfed, so about 222 infants were breastfed, and they found 164 matching infant-mother concentration pairs. The good news was that in 49% of infants, the level of the seizure medication was below the level of detection. So despite mom taking the medication, infant's blood did not show detectable level of that medication in 49% of them. Overall, the infant to mother ratio of the seizure medication was somewhere between 0.3% to 44.2%. So less than half of what the concentration of the medication is in mother's blood. So because the seizure medication levels in infant were substantially lower than the maternal blood concentration, the findings of this study supported breastfeeding of infants by mothers who were taking the medications listed above. So at least in patients who were taking those medications, it was deemed to be safe to breastfeed because the infant's level of the medication was mostly not detectable or much lower than the mom. So back to our patient, our case vignette. SP gave birth to a healthy baby girl. She continued to breastfeed for 6 months after delivery. There was no problems encountered. She had a couple more auras after the birth because she was sleep deprived and there was like all the stress of having a new baby. Basically, her pre-pregnancy seizure control was regained later on. And in the end, she chose to go with IUD with progesterone release after the delivery, so that next time she can actually choose to become pregnant rather than accidentally become pregnant. Now our case vignette continues. Now what? The postpartum care. So during her pregnancy, our patient was treated with oxcarbazepine. The dose was increased from 600 milligram twice daily to 1200 milligram twice daily, incrementally during the pregnancy. And this was to match the baseline pre-pregnancy level of the medication. She had no further auras, and she is now postpartum. She gave birth to a healthy baby girl. There was uneventful delivery. And the routine postpartum care was discussed with her and her husband prior to discharge. About a week later, though, she calls the office and says that she has double vision diplopia. She has dizziness and she cannot walk straight. It was most likely due to the fact that the level of medication was now too high. After the baby is born, you have lost all of that volume of your body. So you are not going to need a high dose of your medication anymore. So the dose of trileptal, the dose of oxcarbazepine was reduced to 900 milligram twice daily. And we held off on further reduction because her symptoms resolved, her toxicity symptoms resolved, and we wanted her to be on a slightly higher dose because it was shortly postpartum and she had a lot of stress and sleep deprivation to deal with. So what happens during pregnancy is that there is increased metabolism and increased clearance of the seizure medications, but sometimes by about 50%. There's increased glucuronidation, but for certain medications due to estrogen, and that medication specifically is lamotrigine, so the level drops rapidly. There is increased plasma volume and volume of distribution. So you see significant decrease in concentration of levetiracetam, lamotrigine, oxcarbazepine, topiramate, and zonisamide during pregnancy. With carbamazepine, the clearance is unchanged. So you don't need as much adjustment with carbamazepine during pregnancy. There are certain medications that we don't have as much information. So we don't have enough evidence what happens to clobazam, to gabapentin, lacosamide. prampanel and valproic acid during pregnancy. So that may be more fluctuating. Some people, they have higher, they have lower levels. Some people may have higher level. So in many seizure medications, you need up titration during pregnancy. The rule of the thumb is that you determine a reference concentration of seizure medication before pregnancy. So all of my patients who are young women who are of childbearing age, I always do a level of their medication before they become pregnant. And when they're stable, when they're seizure free, so I know what the level that treats them needs to be during the pregnancy and later on. At least 2 measures are recommended, and I usually measure both total and free level for medications that are highly protein bound, such as carbamazepine and valproic acid. And I make sure to measure it when they are not on birth control. So if they have to be off estrogen when I measure that level. And then during pregnancy, we do monthly seizure medication level. If there is a drop of about 15 to 25%, you have to consider adjusting the medication, but you don't, unless the patient has auras or like something is happening, we don't necessarily have to. But if the seizure medication concentration drops more than 25% compared to the reference concentration, compared to pre-pregnancy, then a dose adjustment is recommended, especially for lamotrigine. That is true. Once the pregnancy is over, there is a slower drug metabolism. The volume of distribution is now smaller, and the elimination of the medication is also slowed down. So that means that your seizure medication level is going to increase, and patient may develop toxicity and feel over-medicated. The therapeutic drug level should be followed in the first 8 weeks postpartum. So usually my patients have a level right after delivery, a few days after delivery, and within a week, and then 2 weeks after. And then up to 8 weeks, I will do multiple levels to make sure that we know how to adjust the levels. But the majority of the adjustment is done within day 0 to 21 after delivery of the baby. The elimination of lamotrigine, levetiracetam, and oxcarbazepine will decrease immediately after delivery, and they may reach the pre-pregnancy elimination rate by within the 1 to 2 weeks after delivery. So you need to do a faster adjustment with those 3 medications. Now, usually if the dose was adjusted during pregnancy, if you up-titrated the medication during pregnancy, then you must reduce the dose quickly to avoid risk of toxicity. If there were multiple increases in the dose during pregnancy, immediately reduce the dose by about 20 to 25% right after the delivery. And then again, based on the levels, 1 to 2 weeks later, you can gradually go back to the pre-pregnancy level. It is recommended to keep the levels slightly on the higher side right after the delivery because of all the stress that women will face postpartum. And if there was no adjustment during pregnancy, then usually there's no adjustment needed after delivery. That's obvious. Okay, so more trouble can happen if we do not address postpartum care. Our patient SP was sleep deprived due to waking up multiple times during the night to breastfeed her baby. About 2 weeks postpartum, the baby was admitted to the neonatal ICU due to near-drowning accident. She was giving a bath to the baby and all of a sudden experienced a focal seizure with impaired awareness. Now, luckily, her husband was close by and heard some noise and came to the bathroom and was able to rescue the baby from under the water. What are the triggers of seizures postpartum? The main seizure triggers are obvious: lack of sleep, physical and emotional stress, the variable levels of seizure medications in the blood, and then also missed medications. A lot of times mother forgets to take care of herself, and that is why they may forget to take their medications, and those can trigger seizures. Postpartum counseling and safety precautions are absolutely important. Those just as important as prepartum counseling during pregnancy, before pregnancy, but after pregnancy is even more important. To avoid the sleep deprivation, women can start pumping breast milk and store it, and hopefully spouse or family member or like somebody else, hired help, can help feeding the baby at night so that mom can get enough sleep. If giving baby a bottle, you have to make sure that the baby is secured in a crib and feed either like in a car seat on the floor so that the baby is not going to drop during the feeding. For older infants, you can securely strap them into a high chair in a low position for feeding. There are specific types of seizures that are worsened with sleep deprivation, and one of them is myoclonus. People who have juvenile myoclonic epilepsy, that is a very sudden jerk of the body. So that type of epilepsy is notorious to get worse with sleep deprivation and also with alcohol consumption. With mom who are handling the baby, they should try to avoid like early morning handling, because that's the time that usually myoclonus is worse. There are certain precautions that they have to put in place in case of that myoclonic jerk, because you can end up dropping the baby if you have a jerk of your body spontaneously. In case of an aura, you need to place the child in a crib or other safe space. In women with epilepsy who do not have aura, they have to make sure that they do not bathe the baby alone. If they are alone, give the baby a sponge bath, make sure that there is a separate container of water and the baby is not put near the water or in the water. Do not change the baby from a height, do it on the floor, and play and care activities should be close to the ground level, not at a height, not close to a staircase or anything that can be dangerous. Other safety precaution plans: do not carry the baby alone if you have active seizures. Use a small stroller, and the stroller should have special brakes. Keep child supplies on both floors. If you have a house that has 2 floors, make sure that the supplies are on each floor so you don't have to climb up and down the stairs all the time. And keep the baby in playpen and use the safety gates around the baby if you're alone with the baby. Use a child safety harness for toddlers so that they are close by and by you. Again, other safety precautions is that mother with epilepsy should place a message on the baby or near the baby that says this is the emergency contact, and that the fact that mom has epilepsy, has a seizure disorder. So if they're found somewhere, at least people know what is happening. Introduce new moms to epilepsy support groups to share safety plans and decrease anxiety. There was an interesting survey in UK for women with epilepsy, and they asked them, what are you most concerned with? And it was actually, they were concerned about the safety of caring for their babies, rather than even questions about breastfeeding and about medication management came next. The very first thing was caring for the baby and how safe the baby is. That was the most common things that they were concerned about. 86% found that safety information, providing safety information, was actually useful. Contraception should be addressed immediately after postpartum. So moms can become pregnant again. So to avoid unplanned pregnancy, you have to counsel early and about the contraceptive choices out there. And we talked about usually IUD is the choice with or without progesterone release, or medroxyprogesterone injections. Those are the two that can be sure way. We don't usually recommend birth control because of all the hormonal fluctuation, the oral contraceptives, because you have to use a higher level of estrogen, and that can cause a lot more trouble. So our patient contacted her gynecologist and received an IUD and continued with folic acid just in case that any other pregnancy can happen. The last part that I was going to talk about is postpartum depression. And our patient started feeling depressed and abandoned for weeks after the bathtub accident. Although her baby was fine, and she still found it difficult to adjust to her new life situation. And she was very anxious that this can happen again. She had constant fear of seizure recurrence and anxiety regarding whether the baby is going to be harmed. And she was diagnosed with postpartum depression. So what is postpartum depression? Postpartum depression is a non-psychotic major depressive disorder within the 4 weeks of childbirth, based on DSM-5 criteria, which is the manual of the psychiatric diagnosis. So the first 4 weeks after childbirth, if you have major depressive disorder, it's called postpartum depression. The prevalence is about 9 to 13% in general population, but unfortunately in women with epilepsy, the postpartum depression is seen in 27 to 39% of women. And the features are depressed mood, irritable mood, loss of interest or pleasure in doing activities, change in weight and appetite, insomnia or hypersomnia, sleeping too much or too little, loss of energy and feeling worthless, impaired concentration, and recurrent thoughts of death or suicide. Those are the clinical features of major depressive disorder, the postpartum depression. The contributing factors in women with epilepsy is the frequency and type of seizures. So the more seizures, the more likely that they become depressed. Being on polytherapy, being on more than one seizure medication. Unfortunately, lower socioeconomic status can also be a risk factors for postpartum depression. Unplanned pregnancies, previous history of miscarriages, and the stress of parenting. Those are the risk factors for postpartum depression. We need to have a multidisciplinary approach to postpartum care of women with epilepsy. Some women with epilepsy, they feel neglected, they feel abandoned after the birth of their baby. And it is important to help women with epilepsy to become independent in the care for their newborn. And we have to get the nurses, get the obstetrician, the neurologist, the epileptologist, pediatrician, family members to communicate, to coordinate care, and to all have the same voice, and to help both mother and baby to thrive and to have a healthy life. This is the end of my talk. In conclusion, if we have proper recommendation followed by women with epilepsy, the vast majority of them will give birth to normal children, healthy children. The postnatal counseling in women with epilepsy is just as important as prenatal counseling. And without appropriate directions, a lot of women with epilepsy, they feel abandoned, and both the baby and mother are going to be at risk. Postpartum management is not just seizure medication adjustment. There's a lot more involved, and there needs to be support for both baby and mother to stay safe for both of them. And finally, a strong multidisciplinary approach is important in ensuring that both the family is involved, all the medical doctors are involved, in safety of the baby and safety of the mom, and having a healthy environment for both of them. Thank you so much for listening in, and this concludes my talk, and I am here for any questions that you may have. Thank you. Is there any questions, anything that I can address? Otherwise, I wish you a good evening. And everybody's on mute.
Dr. Sazgar, do we need to make any adjustments for devices during pregnancy, like RNS or VNS?
As long as they are seizure-free, no. But if there is any concern about the seizures, in fact, that would be the best way of controlling the seizures, because it is known that those devices do not cause any trouble with the babies. They do not cause any malformation or any issues. So if they have those devices, it is better to actually start with adjusting those if the patient has more seizures. That would be our first choice, rather than increasing the seizure medications.
Okay.
Good question. Anybody else? Thank you so much, everyone. Camila, should I just sign out?
Go ahead and end the meeting. I think we have a question about, will my baby have epilepsy? There might be some questions in the chat. So let's check.
So that is a question of genetic epilepsy. And there are certain epilepsies that are genetic, but not all of them. And that can be addressed if as a part of prenatal counseling. Like basically, if that is running strongly in the family, you can see a geneticist, and there is a certain genetic panel that we can run, and that can explain whether this is going to, like, whether the baby is at risk because of that. Having said that, the majority of epilepsies are not genetic, and they would not transfer to the baby.
Thank you. I think we have one other question. Does UCI have the ability to monitor my baby's health, seeing any possibilities of complications?
You mean like we do have a NICU, a neonatal ICU. So if there is any issues immediately after birth, UCI is equipped to address that. So our obstetric department, like we have basically, as soon as the baby is born, the immediate care, UCI has high quality postnatal care. But I think after that is going to be as an outpatient with the pediatricians, and that would be more of a, then that would be outside of the UCI. But if there is any immediate issues at the time of birth, that UCI is fully equipped to handle that.
Thank you. And we have one other question about, do I need to adjust medications in order to get pregnant?
Not, unless you have ongoing seizure activity, yes. If the seizures are not controlled, then the best is, because if you are seizure free for about 3 to 6 months before your pregnancy, chances are that you will stay seizure free during pregnancy. So the best approach is try to become seizure free before you become pregnant. And yes, in that case, then you need adjustment. But if you're seizure free, we are not going to adjust your medication before your pregnancy, but you have to immediately let your doctor know when you become pregnant so that we can, at that time, then we start adjusting.
Thank you, Dr. Sazgar. It doesn't look like we have any other questions, but thank you so much. This was a great talk.
Thank you. Take care, guys. Bye.
Thank you.